you need to wait 12 hours after a headache for an LP when the CT is normal? And if not, how long? You know, I don't believe you need to wait at all. I think by the time you can get to the emergency, unless you have your subarachnoid hemorrhage, you know, in the ER after you got there for some other reason, by the time you can get to see us, by the time you can get to have your CT scan, and then get everything set up and do your LP, I think do it then.
Well, here's the issue, too. I mean, if you look at the data, you're worried about when will xanthochromia show up. Well, xanthochromia isn't a great test anyway, and it will take up to 12 hours sometimes if it shows up at all. But will there be red blood cells in the CSF? Frequently there will be, and that's been challenged on occasion. Actually, I had that question come up at one of our high-risk emergency medicine courses, and I researched that with one of our faculty members. There's one piece of literature out there to say it may take up to 2 hours maximum for that blood to diffuse across to the point where we will detect it. So that's a good piece of information you can take with you. They had their thunderclap headache, and you did their LP 10 minutes later, maybe you actually won't see any blood. But as Neal said, by the time they get through registration and triage alone, they spent 2 or 3 hours.
Well, there's two versions of xanthochromia. There's xanthochromia where you hold the tube up and look. There's xanthochromia where they actually use a spectrophotometer to measure xanthochromia. The problem with not using xanthochromia is you're going to get about 10% false positives on the taps because you'll get a marginally bloody tap.
The literature that Rick quoted with, you know, how good is xanthochromia, it all just looks at how good is xanthochromia alone, not in addition to with red blood cells. So yeah, if the guy had the ictus a week ago and you think the red cells are gone, sure, that's where xanthochromia is going to help you. And actually CT scan may not be useful anyway because it's so far out. But I think for most patients, do it when you get the time. I mean, it's not like crash bang, but you do it when you can. And I think most cases, there's another question in here, how many red cells do you need to have a positive LP? There is no answer in the literature. There are occasional case reports of hundreds. Most times it's tens of thousands. Most times it looks like Hawaiian Punch, for those of you who remember what that, or rosé wine. I mean, it's usually really obvious that they have that. I think the biggest single problem for us is the question could be traumatic tap. And I think the literature on that is, you know, there's all kinds of ratios to red cells and white cells and all that kind of stuff. None of them are all that good. I think unless you can tell while you're doing the tap, you say, oh, there's a little bit of blood. Oh, now it cleared. That's a traumatic tap. To just say, well, it went from 10,000 to 9,000, from tubes 1 to 4,
and if you
there's
look
no literature for it. I think that person needs an invasive procedure to see if they have an aneurysm.
If you look at reductions, the only real kind of arbitrary data that's the best we've dealt with is Morgenstern's data, said 25% reduction from tube 1 to tube 4. But I'm going to tell you, although a lot of people have clung to that over the years, if you look at where that came from, it was fairly arbitrary, and he just selected that in one of the first articles that he published.
You have to run this video in reverse. Imagine that I do have a subarachnoid hemorrhage, and you gave me a traumatic tap. Then the first tube would have a lot of red cells. The last tube would have a lot fewer red cells, but I've still got a subarachnoid hemorrhage.
I'm with Neal, go ahead and do another study if you need to get neurosurgery to see him. If you're in doubt, they still have blood, you need to think about subarachnoid.
If you think you've got a traumatic tap and it's starting to clear a little bit, take all their spinal fluid. I think just get 4, 5, 6, 7, 8 tubes. Get huge amounts so that the clearing in the last one will be a meaningful one. You know, actually this is a story from the old days, but we used to think that blood in the subarachnoid space is bad for you. It clogs up the pachyonian granulations, you get communicating hydrocephalus. So we think we need to get all that evil blood out of there. So we'd sit them up, stick an 18-gauge needle in their back, and drain them dry. Well, so if you ever wanted to see a spinal headache, well, they already had a subarachnoid hemorrhage, so, you know, what do they know?
Well, the bleeding there was your own blood patch. You just removed it. You should have left it alone. One thing I'll tell you, too, it came out in some recent literature, and it's a current recommendation to add to our CSF panels is bilirubin to look for a subarachnoid hemorrhage. Add a bilirubin to it.
Yeah.
I've often wondered how many red cells, what's the minimum you could have? And the lowest I've seen so far is 77 angioproven.
Well, again, if you tap too early, it could be 0. And if you tap later, it could be 0.
There's no bottom number where it's underneath that number, it can't be.
The usual question that comes up is, why not, instead of doing a CT, just do a CT angio? And then you see if they have an aneurysm. Well, 2 problems with that. One is that you don't see small aneurysms. And second of all, you don't know if it bled. So, you know, what's between 3 and 6% of the population has an aneurysm. So they need a spinal tap afterwards anyway. So now it doesn't answer your question. It'd be nice to say, that you could, but
And the
not
additional
necessarily.
question, too, is, are we only looking for subarachnoid hemorrhage from one cause, an aneurysm? We know there are at least 2 or 3 really good causes for subarachnoid hemorrhage, and CTA and MRA just are not really good at picking up some of those things.
Comment.
If I have an aneurysm, I want a coil in mine.
Thank you. You should get tattooed or something.
Depends on where it is. That was the big push, and now a lot of the studies are saying not so fast. Yes, more benign to put it in, no question about it. More incidence of re-rupture after. I don't, I look a little bit at that literature, not in the detail that I do with this, but a lot of people are saying, one, it's to get the neurosurgeons to ship them all to a center where people do stuff so that gets them out of their hair to say that they need coiling for everything. But I think it's a lot more technical than that.
Now, the question is, once you have the coil and the patient comes in with a thunderclap headache, do you worry more or less about them? I think the answer is you worry more about them. But, please comment on the use of ACE inhibitors for severe congestive failure, pulmonary edema. Do you always use them concomitant with nitrates or later? I use captopril 25 sublingual if systolic is greater than 110 or 12.5 sublingual if diastolic is less than 110. This is at least my knowledge on this subject, and so please help me out with this. ACE inhibitors have been described for their use in pulmonary edema in case series and in no other setting. So the literature on this does not compare them to other modes of treatment in terms of outcome, mortality, all that sort of stuff. At least the literature I'm familiar with is just simply a description of, look at us, we used ACE inhibitors on everybody for pulmonary edema, and it worked. So if I missed some articles,
No,
that's
No,
pretty
I
much it.
think you're right there. It's a second-line agent at this point. But what's good about it, and I like the fact that you're using it, it's got 50% afterload and 50% preload reduction. What else are we using to treat acute failure that has afterload reduction? Nitrates don't get it, except at very high doses. They're preload-reducing agents. So particularly in pretty bad failure, an ACE inhibitor might be pretty good to use, but it's certainly not a mandatory thing. The thing that worried me about the way the question was worded is, why are you worried about using a different form or a different medication because of blood pressure? Are we treating the blood pressure, or are we trying to facilitate fluid removal and reduce afterload and preload? Remember, we're not really looking at this as a hypertensive emergency, and if we are, you want a parenteral, titratable agent, not something sublingual or PO.
Here's what I don't like about ACE inhibitors, is nasiratide could have had the same literature. We used it and people got better. And we're not comparing it to anything else. We don't know what the mortality rate is or whatever else compared to the outcome. The thing that I love about nitro, personally, is that I've had a lot of experience with it. I feel like I know exactly how to titrate it at the bedside. And the most magnificent thing about nitro is if you get into, unless they've been taking Viagra, if you get into trouble, you get out of trouble within a minute or two. And that's not true for ACE inhibitors, definitely not true for nasiratide. So my personal answer to this is I don't use ACE inhibitors primarily because I've never been compelled to. I've got an agent that works for me and works great. Last comment I'll make is in terms of the blood pressure, hypertension and pulmonary edema is illusory. It's driven by a huge amount of sympathetic outpouring. And don't be the least bit surprised to discover that you're 30 minutes into a case and they actually have class 4 cardiogenic shock. This is not class 3 with just pulmonary edema, but they truly have terrible output.
I think at least for me, it's sort of when they're on their way to wherever they're getting admitted to, okay, let's add the ACE inhibitor because it needs to get done and it might not get done for hours upstairs. The bigger question for me is, what if they're on an ACE inhibitor? If they took it last night or, 8 hours ago, do you give another one is another issue. I think for those who haven't, I'm sure most here have done it that way, but I think the way to give the nitrates is wide open. You hang the bag and you tell the nurses to get out of the way, take it off the pump, and you run it wide open until the pressure starts coming down. And you stand at the bedside until that happens, and it's phenomenal. They dry up. They can lean back, they can breathe, they can talk. It's a miracle. And then you start titrating it with numbers and that kind of stuff.
Got one here, interesting. Just as we are urged to rat on the drug-addicted impaired colleague, should we be as vigilant about the dangerously incompetent refractory to mediation physician who may, however, Be well-liked by the nursing staff and patients, willing to work at the drop of a hat, cover nights, weekends, holidays. You know where we're headed with this.
Oh, it's that last part makes the answer clear. They
Well,
got a job in my
You know,
opinion.
I'm glad you guys, whoever wrote this, Maria, you wrote this and sent this up here. I think it's a great thing. And I think if we're really going to be truly accountable and responsible as a specialty and just in medicine in general, we can't apply principles for quality when it's convenient for us. Oh, this is a great physician, but he works or she works nights. Or we get this value added by that physician, so we'll tolerate risk to the patient. If your staffing is bad and you have a bad physician who might hurt a patient, you need to make your staffing worse because you really can't take that risk for the patient, and you have to make sure you're being accountable. So I agree with you completely. You've got an incompetent physician, you have to deal with that as well.
Anybody here work just night shifts?
Can I have your name
Yeah,
and
I'd like to-
address,
can I have your
please?
name?
I got a first-class ticket to Los Angeles. I'm coming to you.
We really, I don't know if where you work you have a chauffeur-driven limousine, take you back and forth to work, and a massage right in the middle of your shift, but, you know, just, you let me know afterwards. And it doesn't matter if you're incompetent. I mean, I'm sorry, that was just,
Imaging in abdominal pain and its overuse. I'm not quite sure about what this question is, but they're talking about a patient gets plain films. Geez, what is a plain film? What is that? What is that thing called? You know, I don't see any plain films done.
$130.
I don't see them done anymore. An
oh,
ultrasound.
no, plain film is what they do right when they're doing a CAT scan. It's that scout film.
They talk about ultrasounds and a CT with contrast. Well, certainly there is a CT with contrast issue. Last year or the year before, we did all the papers that we had trying to make the case that you don't need contrast for appendicitis or trauma cases, oral contrast or rectal contrast. IV is fine for solid organ injury. And the literature, seems to be radiologist proof. They just don't get it, despite most of it being in their literature. Ultrasound, I think every kid who has appendicitis, you think is kind of gray zone for appendicitis, should never have a CT before they have an ultrasound. You have to tell me why you would skip this test that has no radiation to this 7-year-old kid's belly when they have 40 years of opportunity to mutate thereafter.
Our answer is we only had one radiologist that could do it, and he's gone.
Well, I mean, the fact of the matter is that we'll never get better at reading ultrasounds until we start reading ultrasounds. It's a circular argument. Yes. Everybody, you know, if you read the European literature on the ultrasounds in the kids, you know, they're much, much, much better than us in the States. And so what is it? They've just done it more. They've got more comfortable with it. And we just say, just give it a CAT scan because we have so many CAT scans we have 5 per hospital now. But last year we kind of tried to make the case about radiation in kids.
Actually, one thing we did to reduce radiation, I don't know if you've ever tried this, but it's really a remarkable thing, is if it's a really floridly obvious case and it's a male, actually call the surgeon and tell them you have a floridly obvious case, so obvious that you don't even think the patient needs a CAT scan. And they may actually operate. Our surgeons are actually starting to operate on people based on clinical.
Oh my God, don't let that get around.
Actually, where I am, all of our surgeons will do that. In an obvious case, they say, well, it sounds obvious to me, I'll meet them in the OR. And then you have to make up the white count when they ask for that, because you usually don't have it, or it's not back. It's 15,000.
You know,
and then they call back from the OR and say, you know, where are the labs? I can't find the labs on this patient. I say, well, we'll send them along later. Don't worry about it.
Well, my question is why, when it's proven on the CAT scan, do they still ask for the white count?
It might be too high to be appendicitis. How many here have heard that?
Yes.
How many have ever found any literature that even has that in the title or the abstract? I don't know. This is completely made up.
You have to have the white count be 14.3. If it's below that, give it a little shot of epi. It'll get it up to there. If it's above that, give them a little methotrexate. It'll bring it down to there. Or just have a standard, work it out with the lab that there are certain patients on which you're going to want a white count of 14.3 and ask them just to report that out. And repeat the white count, and it should be 14.7. And that proves it's appendicitis.
You know, people have tried to look at where have the CTs made a difference in terms of our false taking out appendices that didn't need to be taken out. And the recurring answer is women. Those are the people who get the most yield out of having a CAT scan. It's certainly not the men. Men don't, they don't have a lot going on down there kind of thing. But women do, and I've got at least 2 papers that basically said, we are better now than we used to be. Let's find out what got us better than, and it was making the diagnosis in females.
One thing that I think should be studied, because I'm convinced it's a practice to practice. Our radiologists always insist on contrast studies for appendicitis, diverticulitis, all these intra-abdominal things. In older patients that come in, they're septic, they got a little belly pain or whatever, to futz around for the next 2 or 3 hours trying to get a contrast CT. I've really taken to right up front, after they get their lab sent off and whatnot, get a non-contrast CT on them. And most of the time, you'll get the answer that you need off the non-contrast. You can always chase that up with a second CT. You're talking about somebody that's 70 years old or something like that, so you might cause cancer in them when they're 123. But for really sicker patients, I don't think it's a bad idea to cut to the chase. And
actually, we have a paper on that specifically and said, let's do a non-contrast first. If that doesn't give us the answer in terms of unequivocal findings, well, then we can go to contrast. And they looked at the subset who were kind of wishy-washy. It turns out about 20% of the patients wound up getting the second scan with contrast. 80% of them, they made a definitive diagnosis confidently on the first non-contrast scan. So that goes along with Peter's strategy, particularly in somebody where radiation doesn't matter. You can just light them up.
Well, this comes up too sometimes when you're saying, listen, I'm going to do the renal study and I want to make sure they don't have a AAA. And invariably, even the tech, before it gets to the radiologist, says, we have to give contrast. We have to know if it's leaking or not. Well, no, you tell me first if there's an aneurysm. If there isn't one, I don't need to know if the aneurysm that isn't there isn't leaking. So you can do the study. If there's no aneurysm there, you didn't need to do anything. One word of caution I'll throw out, too, getting around the contrast issue, we need to keep bringing this issue up so radiologists understand that we're aware of their literature and it's not necessary. But I've heard a lot of docs say, well, you know what I do? I just order the flank study, or I just order a study that doesn't require contrast, and then they don't ask me for it. The problem with that approach is they're looking for the wrong pathology then, and they may not look for what you're really worried about.
One last part of one of the questions. Do you need 2 troponins to make sure it's not an MI before sending somebody home? The literature on this, you would think that if they've been having definite ongoing chest pain, it's been there for 8 hours, 1 negative cardiac injury marker would prove that they don't have an MI. The trouble is that the literature that's out there doesn't say that. It says the longer you've had the chest pain, the more likely the first one is to be positive. So if the initial positivity rate is about 30%, it goes to maybe 60%. But it never goes to 100% with the 1. There is no protocol I know of that says 1 is enough alone. There are some protocols with that and a negative echo and some other stuff, but the 1 alone, I think, at least in the risk management courses I've taught, we call you a defendant doctor.
And and I think the question embraces the notion that if the troponins are negative, the patient doesn't have a problem.
Right.
Yeah, no,
and that's
we know.
Well, and I think
they haven't had dead heart tissue.
I've seen
at that moment.
some of our abstracts you looked at last year. I'm really stated that if you knew the onset of symptoms and you had 1 negative troponin truly 6 hours after, there was some pretty compelling data to say you've probably ruled out an MI. But the big take-home message is just what Peter said. It doesn't mean you've ruled out the entire continuum of acute coronary syndrome. Even if we get 30 troponins in an emergency department visit, why are you sending them home if they're negative? Because you still could have a cardiac etiology for their pain. Got one here for you.
Please comment on the use of delta troponins. I'm actually not familiar. Is that what you mean, change in troponins? Joseph?
Yeah, I think what they say is if it changes by so much, I think it doubles or something, then the next one needs to be longer before you do your third. But the literature on it is like one person says,
we're not going to be waiting around to do our third, are we? We're barely going to do the 2 and they're out of there kind of thing. They go into these chest pain units or some kind of accelerated evaluation process.
Well, we are the chest pain unit where I am. It says, the ankle rules for x-rays. It's hard to follow them if your fellow physicians don't. So this is actually a very more general kind of thing. If you tell people that they don't need sinus x-rays and they don't need antibiotics for sinusitis, and they say, well, my sister was here 2 days ago and Dr. Jones said, no, you need that kind of stuff. I think this is where you have to sit down bring out some of the literature. That's where the abstracts are nice because you don't actually have to read it all. You can just read the abstract. Say, let's try to get a little closer on this kind of thing, or at least say some people would and some people wouldn't, so that when you're the one who doesn't, you don't get stepped on there. I think this is what I always call the preemptive strike. There's a lot of things. I don't do nose x-rays. I don't do toe x-rays. I don't do a CT for stone every time they come in when they've had a stone, or it looks like they have a stone. But I know when they go to the urologist, they're going to say, that idiot Dr. Little, didn't he know? We have to know how big the stone is so we know if we need to go take it out or it's going to pass. And so I tell him that ahead of time. Other people would do it. If he wants one, he can get one, kind of thing.
I think a lot of times when people are, we talked about this before, their expectations are a little bit unreasonable, or they just don't understand the test. A lot of people with ankle pain, they expect an x-ray. But do they know that we're just looking at that for a fracture on the x-ray? A lot of patients I talk to aren't aware of that. They don't know what we're looking at. They just know that's the right test if a test is to be ordered. As I'm going through my history, I ask them, do you think you've broken anything? If they hurt their back, if they have ankle pain, knee pain. No, I don't think I've broken anything. I think, it just hurts a lot and I injured it. Then when I get to the
fracture.
Well, yeah, that's right.
Might not be broken, but it could be fracture.
And then you get to the point of diagnostics. Well, listen, you didn't think you had a broken bone. I don't either, and this is why you probably don't need the unnecessary radiation, and there's a pause, of getting the x-ray. And they've already said that they didn't feel it was broken. You explain what you're looking for in the x-ray, and you've educated them as to why an x-ray isn't going to identify ligamentous injury for them.
Also, if you're uncomfortable using the Ottawa rules, or that the patient won't believe them, use the Viccellio rules. When I see a patient for a lower extremity injury, I will ask them to stand on that extremity and then hop. And then as they're hopping, I go, oh, x-ray's negative, and it works 100% of the time. And I tell them exactly what you're saying. A fracture, I guess you certainly didn't break any bones.
Listen, doctor, you're getting ones on your next breast kidney survey for those people.
How many here are going to, if they think they might have a navicular fracture, just get a CAT scan? Don't do this, come back in 2 weeks, keep your hand in a cast, we won't know. Ultrasound. Oh, you say ultrasound? How many here are doing CAT scan for that? Find out now kind of thing. Interesting.
You know what the ultrasonographic view, what it looks like on ultrasound? This is what the cortex of normal bone looks like on ultrasound. And this is what a fractured bone looks like on ultrasound. And that's all and it's remarkably easy to see. It's a wonderful little thing to use.
We have a bunch of studies trying to figure out what is the best imaging technique for navicular fractures, and basically you get the CAT scan, you get the bone scan. They say that's still good, but the idea of making the diagnosis on the first visit sure is kind of nice, because I'm not interested in being in a thumb spica splint for 2 weeks because somebody's not sure. I mean, I got things to do, places to go, people to see, kind of thing. And I gotta wipe myself. Thank you very much. And I'm not interested in having that CAT scan on that thing on my. Because you're not willing to make a definitive diagnosis, right? I need to know, is it broken or not broken? Thank you very much. Tell me now. And I think that this idea of doing plain films and then saying, well, it's still tender in a snuff box here, we're going to put you in a thumb spike, is nutty. It's 1960s medicine.
See, I think, you look at, they say, well, it's expensive to do a CAT scan. So how much is it to come back to an orthopod's office, get another x-ray, have a short arm cast applied, and maybe reapplied? I would bet it comes out pretty much in the wash.
Well, and my feeling is, I don't know how busy you guys are in your departments these days, but any reasonable, safe shortcut that I can take that isn't necessary right now is a shortcut I'm going to take. Do I need to spend the time to put them in a CT scanner and to wait for radiology to get us a result back when I know that probably half of those patients, when they have their thumb spica splint on for 2 or 3 days, are going to feel better, it's a sprain, and it's off, and it's gone. They don't need any additional tests.
I think most of the literature I've read on this is that nothing's perfect, but you remind me of something. Damn it, I don't know what the result of this was, but there was a lady that I saw that was suspicious for a hip fracture, but she had negative plain films, but she also fell on her outstretched hand and had tenderness in her snuff box. And I remember as I was leaving, the orthopedic resident saying, be sure on MRI to make her put her hand next to her hip. So that they could look for to see if there's something in the navicular. I don't know what the outcome was. I got to. Yes.
Do I really need to give antibiotics for dog, cat, and human bites? If yes, can I just do it for a day or two as prophylaxis? The answer to the second part, nobody knows. I don't think anybody's ever studied that. You know, the usual dose of antibiotics is how long? 7 to 10 days, 5 to 7 days, except for the short course UTI. There's not much else out there studied, maybe some sore throats and some pneumonias, but I don't know anybody's got that answer. Do you really need it for dog? On the hand, I think so. Elsewhere, probably not. Cat, all the time.
That's why they come, because they're infected.
Oh, God, the cats are the worst.
Cat bites 85% infection rate there, and dog bites 15%.
Yeah. And then human bites, yeah, I think so.
And what's
broke in the hand kind of stuff. The bite you on the arm, I don't know that really needs antibiotics.
And what's the antibiotic? Anybody?
Augmentin.
For dog bites and cat bites? Augmentin. Dave Talon did a paper that basically concluded that was the best one. Probably one of the few indications for Augmentin in the emergency department, actually.
If they're constipated and have
that's
another
right.
process, give them Augmentin.
Constipation would be good, yeah.
That's what I
That's
find.
true.
I love the pleasantry that a dog's saliva has 10 to the 6 bacteria per cc, a cat has 10 to the 11th bacteria per cc, and humans with plaque have 10 to the 12th bacteria per cc, which is the same as stool. So next time you're kissing someone, just think of that. It's a...
What a romantic.
Very nice.
You can't pay enough to come to a course like this to go home with that kind of information, can you?
That's your little Valentine gift.
At your next cocktail party, if you want to have the E.F. Hutton comment, just announce that loudly and have everybody turn their head and look at you. It'll be good.
Treatment of recurrent episodes of SVT despite repeated cardioversions and cardioversions. I don't have anything. Of course, they need to make sure their magnesium has been replaced. The tank is fully loaded with magnesium in the recurrent SVT. Anything else, gentlemen?
I mean, if it's a patient you recurrently see back in the ED and no one has taken the first step to put them either on a calcium channel blocker or a beta blocker, you could do that from the ED and say, listen, maybe we can cut down the number of episodes you're having. If that's what you're asking, yeah, I think it's very reasonable to do that.
Here's a good one. I hadn't heard this before. My understanding is that an IV banana bag costs about $190, and PO multivites cost $5. Most patients can take PO multivites, so this would, be reasonable cost savings. Who really come in all the time and get IV thiamine. I actually think the cause of almost all the problems in our alcoholics is thiamine toxicity now. Every time they show up, they get this IV thiamine stuff, and I'm not sure most of them all need it. I think this sounds reasonable, but I've never seen anybody look at it.
No, it's not reasonable. It's not reasonable. There's a reason it's not reasonable. Is if you gave them an oral vitamin in the emergency department, then the cost of that oral vitamin would be $190. They would figure out the hospital would figure out how to buy
the charge would be $190.
Flintstone vitamin for $190.
There is real merit to what you're saying, though. Absolutely. Even the charges at the hospital significantly less, and even administration alone by giving a PO med versus an IV med and mixing and everything, it's a lot less expensive. There's a philosophical issue at the root of this also. Do you think with one dose of multivitamin, thiamine, and folic acid, you're really going to change the nutritional status of your chronic alcoholic in the ED? Why don't we quit doing it altogether? Are you giving MAG also, 2 grams of MAG to them over an hour? I mean, where does it stop?
Well, this is just
Stops
for
with
the
the magnesium.
Wernicke-Korsakoff. This is just that one-time dose so that you can then give them carbohydrate-containing stuff. It's in old literature. These were really, really bad alcoholics, chronically malnourished people that get it. But it's sort of to take that issue off the table in terms of if they start getting really bad in the next 2-3 days.
You know
that's not the
where
issue.
actually I think this is a really important issue and a potentially life-saving or life-threatening issue is treatment of hypokalemia. Is 99 times out of 100, this should be doable with PO potassium and not IV. And when you have a misadventure with IV potassium, it results in the death of the patient. So that's one area. I will always try to push as much as possible toward oral rather than IV potassium supplementation.
How about propofol for refractory seizures? Anybody know anything about that? There's even a dose down here, so this doctor must know something that's out there. Anybody?
I don't know how it was found.
Haven't seen anything.
Do you then do, this is like after you failed benzos and real anticonvulsants, and then, though, do you make them unconscious with it? Because most people would say then you need to have continuous EEG monitoring, because you can suppress movement and not all the...
Milligram per kilogram to break the seizure, and in many situations it doesn't come back.
So it's like an induction dose kind of thing. Yeah.
Yeah. Hey, I've read like cases of this where it works. You give it and then it wears off and the person stops.
Case report of one personally, about a week and a half ago, 11-year-old with cerebral palsy came in, status epilepticus, known seizure disorder, 2 VP shunts in, and he needed RSI, went ahead and rapid sequenced him, and as he's starting to wake up a little bit, I mean, he still has nystagmus, so he's still in status. What I used for mechanical ventilation sedation was propofol. And it also stopped the nystagmus. I honestly think it broke his status. I'd have no way to prove that. From a case study of one, it looked pretty good to me.
Yeah, it'd be interesting to know how long it lasts, is the issue. Because if they're that refractory, how long it's going to last. I think you had a comment there.
Here's some from the same night doctor. Studies to allow nurses to use ultrasound to place IVs in PEDS patients. Tomorrow we're going to do a section, 1/3 of the truism sections is about anesthetics in association with IVs and trick to starts IVs, and there's papers in there that talk about ultrasound, and there seems to be absolutely no reason why nurses could be not taught this technique, and in fact, nurses were taught these techniques in a couple of the papers that are in that chapter.
Comment on bicarb for rhabdo. It seems logical to alkalinize the urine, but literature is equivocal. I will concur. I've never certainly seen I don't know that anyone would be able to get through the IRB, a randomized trial of rhabdo with or without bicarb, and it would take forever to do, and you'd have to overcome the nephrologist's objection to do it. So I think this is going to be one of those things we just continue to do because it's logical.
Yeah, the ship has already sailed on that one. It's part of the standard and no real reason to refute it. We got one here. Interesting question. I think it's a two-part question. Is there an absolute BMP value that warrants admission for persons with chronic CHF? Well, the first part is very easy. Chronic CHF, they're always going to have elevated levels. No, you shouldn't base your admission decision for a chronic non-decompensated CHF patient based on that number. One step further, the second part of the question that isn't written here is we shouldn't use any BMP to make decisions for CHF in any patient in the emergency department. It's not a good test. You know, it's interesting, if you look at the data on it, and just this is an oversimplification and maybe just too brief of a summary, but yeah, some of the numbers are good when you say, wow, look, this BMP in this person was 5,000. Yeah, they had pink frothy sputum and they had a whiteout on their chest x-ray. Did you need an additional test to give you the answer you already had? And you have somebody with a fever, purulent sputum, a history of COPD, and they're wheezing, they don't look like failure at all, and you say, see, look, the BMP was 20. Again, you didn't need that test to help you. Where we need the help are the gray zone cases. The person who has a history of COPD also has a history of CHF, maybe a little edema, but they have a low-grade fever. The x-ray is equivocal. I'm not sure. And how does the test perform then? It doesn't perform well. So just don't use the BMP at all. And it's $43 a shot on the average. So
yeah, you get gray zone results in gray zone cases. There is one particular diagnosis where you'll get strikingly high BMPs, and yet the patient won't have failure, and that's in true high-grade sepsis. That's been well documented and carefully done studies with swans doing cardiac outputs, ejection fractions and whatnot, that you can have a normal heart and have BMPs 2,000, 3,000, 4,000.
Well, though, out there on the, you have the discs of last year's course. One of the half hours last year was on things that will raise your BNP and your troponin that are not really related to the failure or ischemic heart disease. And there was a long list of stuff.
Everything, I think, was on that list. Yeah, comment.
Yeah, you know, actually, one of the things I like the BMP for is getting some of your chronic cardiomyopaths admitted. Because if I'm looking at the BMP that I know this guy's baseline is normally 2,000 and he's 6,000, I know I'm not going to cure him in the ER, so I can call his primary and say, this guy just needs to come in.
As somebody mentioned earlier in the course, a BMP sometimes gets them admitted when they won't believe your exam and they won't believe you've been trying forever to diurese them. And you say, oh, but the BMP's 1,000. Oh, I'll put them in. But do they need the ICU? you know.
Is there any studies to support the idea that milk makes you have more mucus in the setting of a URI? Gives you menuchus. I've not seen one. I'd love to see one because I'd put it in the abstracts if I did see one because you hear this drivel so many times.
Is this from drinking milk or pouring it down your lungs?
So the question is there any data? I'm not aware of any data. Any of you aware of any data about milk and mucus? Both begin with M, must be related.
I'm not even, you know, most of these things start out with some sort of underlying pathophysiologic principle that gets extrapolated down the road. I can't even think on this one what it might be. You know, I know about lactose intolerance after you've had a gastroenteritis and all that kind of stuff, but this I can't even imagine where it comes from.
Well, it comes from, we could call out the name.
No, that's common.
There's one for you. Can we use ketamine for sedation when doing a lumbar puncture in a child to rule out meningitis? There's the theoretical risk of increased intracranial pressure from ketamine. Well, aren't those kids going to have elevated intracranial pressure anyway if they have meningitis? I mean, a few more millimeters, even if that's theoretically true. I've not seen any papers on this. Gentlemen, any papers?
Well, I mean, you hit the nail on the head. It's a theoretical increase in intracranial pressure, and then you look at trauma cases, it's insignificant. It's not an issue, and I've used it for that purpose as well, and I think it's perfectly acceptable to do
Actually,
that.
because I sedate virtually everybody for lumbar puncture, and I think when you get fairly deep sedation, you get elevated intracranial pressure because they're retaining a little CO2. So you need to encourage them to breathe real hard so that you just don't get a falsely elevated number.
But also probably putting them in the position for LP elevates their intracranial pressure. When you track this down, almost anything you do changes the number. Putting a collar on a trauma patient elevates their intracranial pressure. What no one has ever shown is whether or not the changes in these numbers actually matter at all for these transient
Well, just
things.
tell somebody they're going to have an LP, and trust me, their intracranial pressure goes up.
Any evidence, any evidence-based medicine that says giving topical anesthetic eye drops should not be taken home? Yeah, wouldn't that be great, you know? Because we take them home. You know damn well we're going to take that bottle home with us.
The answer is no, and I know Jerry Hoffman tried to get a study done where people would do more prolonged use of eye drops for corneal abrasion and that kind of stuff, and he couldn't get any ophthalmologist to sign on to the study because they say, yeah, we know the literature is terrible, but don't put my name on that kind of study. So it has never been looked at. I think it'd be good to look at just long-acting local anesthetics. Just give them Marcaine. But I don't think anybody's brave enough to do that.
Hibiclens in MRSA after INDing an abscess. Is there any evidence that that's any better than anything else? Not that I'm aware of.
I'm sure if it was sponsored by the Hibiclens people, it would be shown to work.
Actually, we have a paper coming up in the abstracts looking at the effects of topical antibiotics on staph infections. They're comparing polysporin and Rite Aid's staph cream, kind of whatever they had. There was an in vitro study looking at the difference, and yes, there is a difference between their ability to kill bugs. Whether that's clinically relevant or not is unclear.
The latest thing I've heard is copper. How many have heard that? Copper surfaces kill bugs. And so there's a move to make all the bed rails in the ICU and all the touchable surfaces and everything made out of copper. This may be the copper industry doing it, but apparently there's some fairly decent data on this kind of stuff, and that may be the way around this. This is part of the economic stimulus package.
In the face of blunt trauma, like a fall from a horse with microscopic hematuria, we use CT to evaluate low-grade splenic injury. Although the renal risk is frequently discussed, the association between hematuria and splenic injury has rarely been reported. Is the association too rare to worry about? I think you judge it by the company it keeps. If I'm kicked over here, right by my kidneys right next to my spleen, I would think they would be congruent injuries. I'm not sure what the question
Actually, there is a literature on it. It says if you have trauma and you have blood in your urine, you're more likely to have a ruptured spleen than a ruptured kidney. It's just a non-specific marker for abdominal trauma, and just kicks you up a notch in terms of your level of concern, that especially in the so-called benign kind of patient, maybe there really is something going on there. And then the other thing that's been shown with this is with minor trauma and some microhematuria, renal abnormalities. You pick up cancers and other kinds of stuff.
If you look at isolated renal trauma, if you're just considering that in and of itself, first off, if you have microscopic hematuria, you don't need to scan them at all. They need to repeat your analysis, and if that clears, they're done. If they were hypotensive in the field, or they have gross hematuria, well, then you probably need to do a study. What's interesting about splenic injuries, and I don't know if you've had this experience, our group has had this over the last 2 years, of docs doing a reasonably good job evaluating a patient, good abdominal examination on the patient, seems like there's no splenic injury, no splenic tenderness, and 48 to 72 hours later, they come back with significant change in either hemodynamics or their exam, and they've got a ruptured spleen.
What's the chest exam on those? Because there is literature that's
Normal. I mean, normal. I've
you
reviewed
know,
all those
ninth,
charts.
Ninth, 10th rib fractures, about 10% of those
Yeah,
have a
those are
spleen.
normal. We've had a good number where it just makes me scratch my head and say, how can we avoid missing some of these cases? Because they weren't, when we looked at it with our internal peer review process, you know, our quality committee looked at it and said, you know what, and it's blinded, it's redacted, they don't know what the outcome was. No, it was good care in the first visit. Then I let them know, here's what happened. And everyone's like, wow, I would have missed that too. I don't know where we're headed with this, but it just needs to be put in the front of our minds that you can have an occult splenic injury on your first visit, and it can easily slip past you.
One of the problems at a trauma center is that every now and then you get a case like this, and it reinforces the pan scan everybody, and it's.
Although you have to remember that smart ER doctors will create charts consistent with their disposition. And if that person that you're intended to send them home, you'll create the go-home chart. And then a review of the go-home chart will not find any reason for that person to stay because the doctor created a go-home chart. And last thing, there's this doctor here mentioned all of the uses of ultrasound in the ERs these days, fast CAT, central line, peripheral line, and we'll have some papers on the peripheral lines tomorrow in nurses. DVT, gallstones, kidney stones, ectopics, and intrauterine pregnancies. And now, unfortunately, us old doctors, I'll speak for, do you know how to do ultrasound?
I do some, not much.
The old doctors don't know how to do this. We know how to check the box. But, you know, I sure wish I had, you know, been in a residency where I basically learned all of these kinds of things, because it's this, the ultrasound probe is the stethoscope of the future kind of thing. That stethoscope, carrying that thing around, I have no idea what it's supposed to do anymore.
Oddly enough, I find the whole central core of these things, like looking for gallbladders and whatnot, as time goes on, I find them less and less valuable. And for other things, I found it more and more valuable. If you want to look for a retinal detachment or something like that, nothing better than ultrasound of the eye. For looking for navicular fractures, ultrasounds can be fun. If you have somebody needs to do this study where for lateral malleolus sprains, if you do an ultrasound of the distal fibula and it's negative, do you ever have a fracture there? Probably the answer is no. So it's a very quick way at the bedside. So there's all sorts for cellulitis versus abscess. The physician's clinical judgment, one of the papers that was in Emergency medicine abstracts, it was like 50% error rate. So using ultrasound to define whether or not it's actually an abscess or not. Peritonsillar abscesses to identify them.
In I haven't done this, but I've seen a good presentation for eye trauma where their eye is just swollen shut, and you're supposed to somehow figure out if there's something going on with their eye, and you just kind of sit the ultrasound probe in the gel. You don't even actually put pressure on it. You can see the whole eyeball, see if they have a ruptured globe, look at their retina, look for detachment, do all that kind of stuff. And then, as I mentioned earlier, in the patient that's the, quote, surviving sepsis kind of thing, where you look at their inferior vena cava, and if it's flat, they need fluids, and if it's dilated, they need pressors, is a good thing for people who are sophisticated in using this.
There's something I learned from my father when I was 6 years old, and I went on a house call with him, and I've never ever seen this taught in medical school. It's for a diagnosis of acute glaucoma. What happens in the emergency department if you don't, how do you diagnose it if you don't have a tonopan? Just feel with your thumb. Feel the eyeball that they're not complaining about and the eyeball that they are complaining about. This one feels like an eyeball, that one feels like a rock. And I learned that when I was 6 years old. I was palpating this guy's eyeball on his back porch. And,
if you diagnose it that way, it'll help you. If you miss it using that,
yes.
Trust me, a jury of lay people are not going to tell you did what? You poked him in the eye and thought it felt normal. Well, it wasn't normal. Just in the eyes real quick, I think it's important to discuss for a moment. How many of you are doing slit lamp examinations on every painful red eye? You really need to. You know, when I float from one emergency department to another, I know there's a significant issue with evaluation of ophthalmologic complaints when I walk into the room and the nurses have put out the Woods lamp. Because that's what the docs at that site are used to using. If the Woods lamp is out, we have a problem. You're going to miss a lot of pathology with the Woods lamp. We need to get comfortable using the slit lamp and use that on every painful red eye.
However, you need to be comfortable with the Woods lamp because that may be the only thing you can use on a 1-year-old.
Sure.
It's a little tricky.
Well, it's not hard to learn how to use a Woods lamp, that's for sure.
Yeah.
Got another one here. This individual works in a small community hospital. When they have STEMIs, a cardiologist group wants them transferred to 30 minutes away, and they don't want anything done, and they don't want lytics given. Well, the first part of the question is, it's a page long, so the first part is, should you give lytics or not? There is pretty good information on this, pretty good evidence. If you can get that patient to the cath lab, needle in, and balloon up in 90 minutes, don't give the lytics, get them where they need to go. But that doesn't mean they're going in through the door of the other ED. It doesn't mean they're almost there. The balloon should be up. And so, do you need to give these patients lytics if they're 30 minutes away from the other hospital? Probably not. The cardiologist is probably right there. On the additional parts of your question, they don't want you to draw labs, give any care, do any transfer paperwork, send the transfer paperwork later. That's problematic. There is still a standard of care of what you need to do to stabilize those patients from a medical legal standpoint, and then from a medical screening examination from an EMTALA standpoint about appropriate stabilization to the extent of your facility's capabilities. And if you're not given anything before sending in, there's a bad outcome, that's an issue and a problem. You said
see, we're on the receiving end of this, and what we've worked out is with any emergency department in our area, they see the patient, they diagnose on EKG, and the next thing they do is pick up the phone and call us. We immediately accept the patient, and all they do is put in an IV, and they may or may not draw some labs. But other than that, what else can they do to stay?
They said here, no IV starts, nothing. These cardiologists
no,
want nothing done.
Obviously, they should
That's
get an
silly.
IV start.
But you can get some nitrate started, give them some aspirin, put them on oxygen. Now, what's interesting about heparin, never make that a first-line therapy for you. Heparin is only used to keep the vessel open. Once they open, it's not going to open anything, or we wouldn't need thrombolytics. So if you don't have the vessel open, don't spend your valuable resources with your nurses mixing heparin and hanging heparin. They will do that in the cath lab once they get the vessel open.
Actually, my hospital is about 25 minutes away from both University of Michigan and St. Joe's, both big cardiac centers, big active practice. And actually, our first phone call, if the ambulance comes with somebody, we don't let the ambulance leave, and we just put them back on their ambulance stretcher so that they can't go out into the rest of the world and be lost to us. And then we just send them, because our cardiologists have said, send them and then call us. And if you're wrong when they hit our cath lab, we'll tell you later, but we won't badmouth you. And we'll do some basic stuff. They get aspirin and a few other things. And so in order to get that door-to-balloon time at 90 minutes, you've got to shave everything off. And the biggest single thing is calling another ambulance. We actually have an ambulance site on site at our hospital, but they may not be there. So our biggest part is that, and they say, if we don't answer the page back right away, don't worry. We will have somebody at the cath lab ready for them, and we're just able to do it at that, but it's tough. And
we've lost our cath lab about 4 months ago, and so we've been sending them to the regional STEMI center, and that's about the first call that we make is to the fire department. The fire department in our place has agreed to transport these patients from our hospital to the other hospital, which is about 15 minutes away. So we're not sending for any of these critical care transports, which will never come in any reasonable time. The fire department's there in 5 minutes, and then they'll draw some blood. But nobody's waiting for anything, because all of the cardiologists in this it's about get them here right away, get them here. And the sicker the patients, the more the reason they need to go. You're unable to stabilize these patients. They're not stabilizable. And we're talking about a 15-minute transfer with paramedics. We have the option of putting one of our nurses in there, although I don't know that we haven't done that yet. And they haven't expressed any big desire to go.
You can identify some clearly bad practices. If when you see the patient, then they're having an anterior wall MI, if you have to do anything other than call the receiving institution, you have a bad system. I mean, obviously put an IV and whatever, but if you have to call the private cardiologist and let him know and get permission and let them do a wallet biopsy and whatnot, you're just doing harm to the patient. It's got to be one phone call out the door and on the way.
And in terms of the therapy, none of this stuff that on half-dose TPA or trofarofaban or any of these 2B3As, nothing. They get nothing, because the literature says they don't need anything.
In terms of records, you can fax everything. They don't need to leave with paperwork in hand that you may not have even filled out. at the time they're there. I don't have any problem with that. If you want to draw and send labs, you obviously don't wait for anything. You fax those labs to them. In fact, you're required to send everything, at least in the U.S. under EMTALA, everything you've done, they need to have results on. So if you have the septic patient, you're transferring them, you've gotten blood cultures, you better be sure your lab knows that 5 days later when they're positive, they go to that hospital, because that's part of the EMTALA issue.
Kevin?
And one more from the same individual. With that same issue, it sounds like they decided to take TPA off the formulary because they just weren't using it. And then I guess they were providing potentially TPA for stroke, and neurologists said, listen, we shouldn't be doing this. If the hospital can't afford it, we shouldn't be providing stroke care. I know I may be over-summarizing this, but basically the question was, they've set up a transfer policy where anyone who has an acute ischemic stroke goes to a regional stroke center. I think it was 30 minutes away. And the question is, medical legally, is that a good thing? Are you off the hook? You know, what most emergency departments don't have, which is the critical piece, is a policy stating how you're going to handle stroke. It's not so important whether you're giving lytics or not from a medical legal standpoint. It's that you have a policy saying, if we do or we don't, this is how we're going to do it, and we followed that. I think it's very important that if you're not going to give lytics, which a lot of us don't want to, or a lot of facilities aren't able to appropriately, then you should have the policy that says, we just don't do this as an institution. And then when you follow that policy, there is really no risk management issue. But when you make it as an individual decision as a physician, then you have some real issues, because the plaintiff's attorneys have really looked at this as a false standard of care. False to us, not to them. And there's a lot of litigation out there on both sides of this, giving it and not giving it.
Yeah, he mentions there if they have a big PE and you can't lice them. I can't imagine why you would want to take it off formulary. I don't know where you are, but we're 25 minutes away from another major hospital. But, you know, we got ice storms. We got helicopters that can't fly. We got ground crews. We got ambulances that are all taken up in the community. And we need to lice people, at least for heart attacks sometimes. So I think not having it around is a little bit too much head in the sand.
I'm going to guarantee they still have amyl nitrate, right? I mean, there's certain things that aren't necessary that we keep, certain things
the
that...
Lilly cyanide kit?
Oh, exactly. Right. Certain things that we really should have because of the kind of events that Neal's talking about, the kind of event you're talking about, that you just have to have it when you have that case. And I'm a little concerned for you also that they won't let you have in your formulary what you as the clinician feel you need to take care of patients with.
Okay, all right.
Okay, this is the drum roll again. Dun, 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 dun.
You've watched way too much daytime TV if you can actually do that theme.
Joseph, I'm sorry you lose because we can't read your last name.
Dr. Handwriting.
Lena? Oh,
Yep.
that's you? Okay. All right.
Congratulations, Joe.
That's right.
Congratulations.